All right, ladies and gentlemen, I am so happy to see so many of you joining us this evening. Thank you once again for joining us for our fireside chat tonight. We are very fortunate to have a wonderful panel of individuals who are here who have very generously agreed to be sharing their story. And in addition, of course, we have a professional, Dr. Lee, with us, Professor Lee, with us this evening. Before I get things started, I want to just please bear with me as we go through some of the etiquette before for the evening. I ask all of you to please keep your videos on mute. And if you have any questions, you're more than welcome to write them into our chat box. But in the meantime, please refrain from turning on your microphones. We want to allow our panelists to be able to share their stories as well as give a better understanding of an introduction to depression. And then we will get to Q&A following that, and we'll try to address as many of your questions as possible. So without further ado, let me just start the ball rolling tonight. I am Nadia. I am a volunteer with Caregivers Alliance Limited. Caregivers Alliance Limited is a nonprofit organization here in Singapore, and we are dedicated to meeting the needs of Singaporeans or those in Singapore who are caregivers with loved ones with mental health issues. While there are plenty of wonderful organizations in Singapore that cater to lots of people with different types of mental health issues, CAL is specifically here to provide support to caregivers. And I myself have been able to been a part of this community for half a decade. And I'm so pleased to see so many of you have joined us tonight. Even if you've never attended our classes yet, this is a good opportunity for you to get an introduction, which is normally what we do in our classes anyway. So CAL is an approved institution of public character, and tonight we are honored to have highly esteemed psychiatrist who is not a stranger to CAL and our caregivers, Professor Lee Cheng. He himself is a father who dearly loves his daughter and works to be a better caregiver for her sake. And in addition, we also have Gabriel, who has been caring for his beautiful daughter, Kristyn, who is on our chat today. Kristyn, thank you so much for your bravery and your generosity for wanting to be on a panel with us tonight. It means a great deal to the rest of us. I'm sure you know that, and I've told you that so many times. And I can't wait for all of you to hear her story as well. Please, as I mentioned earlier, at any point in time, if you have questions, do drop them in our Zoom chat. We will get to them as soon as we can, but just bearing in mind, we do have quite a wonderful response tonight. So we'll try to get to all of your questions, or at least the key ones, because a lot of questions tend to be quite similar. We also appreciate for you to keep your microphone on mute for now, because we want to be able to give platform for our panelists to be able to speak clearly, and towards the end of the evening, we'll be able to get to your questions. Also, a gentle reminder that tonight's session is recorded. So if anyone of you in attendance today, it does not consent to being recorded, I ask you to please either exit, keep your screen on, keep your video off, and also not to worry, because our recording tonight will be made available at a later date. So as I commence our fireside chat tonight, an introduction to Depression 101, breaking the myths and misconception, I want to first highlight that according to the National Health Study by Ministry of Health, depression is the leading cause of mental illness within Singapore. I myself am a person in recovery. I was diagnosed with a major depressive disorder in 2016. And through a combination of the support group that I've been so fortunately surrounded by, as well as the community at Caregivers Alliance Limited, I've been able to go on this journey of recovery. And of course, I'm very blessed to have other persons in recovery like Kristyn and her father Gabriel, who have been so generous in wanting to share and raise awareness about what the experience has been like for them as well. So, with depression being the most common mental disorder, both in Singapore and worldwide, why are people uncomfortable to talk about it? Is it just all about feeling sad and down? And what should we do to support those who are experiencing such symptoms? Now, in the first part of our session, I would like to invite Dr. Lee to explain about the illness, the onset, and symptoms. In addition, we also want to be able to address any misconceptions around it, as well as talk about what are some of the treatment options. In the next half of this evening, we will invite Father Gabriel, actually Kristyn's father, Gabriel Chan, and talk about, gosh, I really love their story. So Gabriel and Kristyn, I've known Kristyn, I've known about their story for a couple of years now, and it's really heartwarming to be able to hear from the perspective of a parent as well as a person in recovery, Kristyn, who is very fortunate to have the support of her family. And so it's always important for us to learn through lived experiences in members of our community who have lived experiences. And I am not going to hold up too much of their time anymore. So first, let me introduce us all to Professor Lee. Professor Lee, I'm handing over the floor to you, but before that, can I trouble you to please tell us a little bit more about yourself?
Hi, good evening, everyone. I hope you can hear me. I'm Dr. Lee. I'm from the Institute of Mental Health. I'm also the clinical director for the population health in IMH. And essentially, the purpose of the Office of Population Health is to increase the mental health literacy of the public so that there is less stigma associated with mental illness and hence less delay in seeking help. As a volunteer, I'm also the president of the Singapore Association for Mental Health, as well as the immediate past president for the Civil Women's Singapore. So I have been a psychiatrist for the last 20 odd years since 1997, being graduated from the local medical schools in 1990. I think that's all I want to introduce on myself. I think we can talk about that later on. I will proceed on to the topic I'm asked to share with all you today, which is depression. And earlier on, Nadia did mention about the frequency of depression, of the prevalence of depression. So I think we'll go to the slide proper now. Sorry, there's some technical problem. I can't progress my slides, so I'm waiting for the staff to assist me. Yeah, okay. So it's going downwards, huh? Okay, great. So just to highlight, the Singapore mental health study was done in 2016. That was done almost 7 years ago, because for the study to be published, it takes some time and for it to be conducted. So in that study, 1 in 7 in the population experience mental illness in a lifetime, and of which the top 3 most common disorders are, not surprisingly, what we call major depressive disorder. By the psychiatrists, by most of us here, will probably call it a depression. The second most common is alcohol abuse, and the third is obsessive compulsive disorder. So the topic today is on depression or major depressive disorder. So I will not be focusing on alcohol abuse or OCD. Maybe Cal can consider that in future talks. How have our mental health improved from 2010, the mental health study, versus the 2016? You can see that from 1 in 8, we now have 1 in 7 experience a mental illness in a lifetime, although the statistically is not very significant for major depressive disorder, but nevertheless, you can see it's from 5.8% increased to 6.3% from 2010 to 2016. Fortunately, you can see from this slide that the treatment delay in terms of years has decreased from 4 years for MDD to 1 year, which means the patient are more likely to seek help. Although the one for OCD, you see that there is an increase from 9 years to 13 years. So for patients with OCD, they tend not to seek help compared to other illnesses. I just want to share a case study. This is just to illustrate some of the symptoms or some of the complaint that patient with depression may exhibit. This is a patient that is called her Mrs. Lim. As a psychiatrist, I cannot share a patient case. So this is to be frank, this is a compilation of multiple cases, but I will just call her Mrs. Lim. Mrs. Lim is about 13 years old. She worked as a hotel supervisor. She's currently undergoing a divorce with her husband after finding out about the husband's extramarital affair. They have a 10-year-old daughter with special needs currently living with her, and there was a helper taking care of the daughter. The relationship between her and her own family is not good, and she started to feel that she could not cope with these challenges in her life. She had disturbed sleep, and she was not able to eat well. She used to enjoy going out with friends to relax, massage, facial and whatnot, but she has stopped doing so. A couple of days ago, before she came to see us, she felt like jumping down together with her daughter to end their sufferings, both her daughter and herself. And on a certain occasion, she went to the supermarket and left without paying any grocery items. So what is Mrs. Lim suffering from? Since the topic today is depression, I think we are going to talk about depression. Over the last 2.5 years, 3 years, also because of COVID pandemic, a study by us, by RMH, showed that 13% has symptoms of depression and anxiety during this period of time. And I just want to share that symptoms of depression doesn't necessarily mean that you have depressive disorder. You had the symptoms, but you may not have the disorder. So depression by itself is a common disorder. It's commonly often missed. It can be severe and often be recurrent. It's costly in terms of the treatment. We also have what we call intangible costs, as the patient may have problems interacting with the family members, and there will be some family stress, as well as the patient may not be able to work. There will also be some economic impact. However, depression is highly treatable. So depression by itself is a common psychiatric illness that negatively affects how a person feels. That's what we call cognition, how we call emotion, and how the patient think. That's what we call cognition, and act, the behavior. So there is 3 components in terms of the emotion, the cognition, as well as the behavior. And this is important because later on we are going to talk about CBT, with cognitive behavior therapy, which essentially target on these 3 components. So depression is not simply just a feeling of sadness or loss of interest in certain in things that you lack over a short period of time. It's usually characterized by a prolonged, and we use the word prolonged, i.e. more than 2 weeks in this psychiatric term, of the feeling of sadness and loss of interest. And these are the 2 what we call cardinal symptoms of depression. There are other symptoms of depression, but the most important symptoms are feeling of sadness and the loss of interest. And importantly, for any psychiatric diagnosis, there must be an impairment in functioning. So if a worker, they cannot work, a housewife, she cannot perform housework or take care of the family, or a school kid, the person may have problem with the academic performance of schooling. So how common is depression? This is just to show that the lifetime prevalence, and the lifetime prevalence is over here defined as the number of individuals in the population at some time in their life that may experience that disorder compared to the total number of individuals. So the lifetime prevalence of what we call LTP is about 15% for men and 25% for women. And the point prevalence, which again more specific, referring to the period of time, is about 1.8 to 3.2% for men and 2 to 9.3% for women. So it's much commoner in females. The age of onset of depression can be any time. although the average age onset is usually in the adulthood, late 30s. Not surprisingly, it's more common in people who have poor social support, for example, people who are single, divorced, or separated. How serious is depression? Is a serious cause of morbidity and mortality. That's what I meant earlier on, because it's associated with the costly impact whereby the person may not be able to function, the social functioning as well as the physical functioning. Also, it increases the mortality through suicide, accident, and medical illnesses. We are aware that a person with a psychiatric condition are more prone to a medical condition. Similarly, a person with a medical condition is more prone to a psychiatric condition. Again, to emphasize that a depressive disorder is an illness that involves the body, the mood, the thoughts. It affects the way a person eats, the person sleeps, the way one feels about himself or herself, and the way one thinks about things. So it's not just the same as feeling sad or a transient episode of feeling blue. However, sometimes there are some stigmas associated with depression. It's commonly viewed as a sign of personal weakness or condition that can be wailed or whisked away easily. So when we see a person with depression, some people will advise them, pull yourself together or it will get better over time. It's not just that. Without treatment, symptoms can last for weeks, months, or even years. Fortunately, appropriate treatment can help most people who suffer from depression. What causes depression? Like many psychiatric disorder, we always use the 3P to understand about the genesis or the causation of any form of mental illnesses. First is what we call predisposing factor, the first P. The second P and the third P are referring to stress. Essentially, what are the stress that lead to the condition, the precipitating factors, and if the stress is not removed, it becomes what we call a prolonging factors or perpetuating factors. So maybe I will just briefly mention some of the common predisposing factors. We do know that genetics play a role. For example, family members are 2 to 3 times at higher risk of having a psychiatric condition if one has a psychiatric condition in the family. The other thing that commonly associated with depression is what we call the neurotransmitters. For those of us who are aware that treatment with antidepressant take a couple of weeks to act, that's because they need to balance the neurotransmitters, specifically what we call the serotonin as well as dopamine. And again, hormones play a part. Earlier on, we mentioned of females having a more likelihood to have depression. We do know that, for example, some females during their menstrual cycles they experience some form of low mood, and during the pregnancy or postnatal period, they also have more likely to experience depression. Psychological factors are also important. A personality of the individual, for example, some person may be by nature more anxious or more worrisome or more what we call gamjiong in our local term. So that is our personality or what we call character and psychological makeup. As mentioned earlier on, you have the vulnerable factors of the predisposing factors. You require the stress to lead to the so-called the start of the depression. And the precipitating factors can be any form. It can be the form of a psychosocial stressor. For example, you have some difficulties in coping your life because you belong to the lower social economic status. You're not able to cope with the financial issues, or you experience some form of life events. Migration is one of the common association factors with psychiatric condition. For example, you migrate from one area to another area, you have poor social support because you may belong to the minority group. Physical illnesses like cancer, Parkinson's disease, and I earlier on mentioned childbirth, postnatal depression is also what we call psychosocial stresses. Another form of precipitating factors is what we call substance abuse. We do know that sometimes patients with depression, they will take substances to so-called self-medicate, but at the same time, substances may lead to the start of the depression. So if all these factors, we do not remove them, the precipitating factors become perpetuating factors. And that is very important because treatment is not only medication alone. Although I'm a psychiatrist and I do give patients antidepressant, the removal of these stressors are as important as the compliance with medications. We'll just wait for a while. I now have problem again with posting the slide. Okay, I need a lady beside me to help me. So what are the symptoms of depression? It all depends on the severity of the disorder, and it can present with a variety of symptoms. Earlier on, I did mention that we need to distinguish between symptoms and the disorder. So what are the common symptoms associated with depression? For simplicity, I will always like to use this example, insect cages. It's just a person who are very depressed, mean we're isolated. He or she will be in a world of his own or her own, and that is like cage. So the IN stand for diminished interest. As mentioned earlier on, interest is one of the most important cardinal features for depression. So diminished interest. So things that you enjoy in the past, you like reading, you like go for a movie, you like running, you like jogging, anything, you start to have decreased interest. SA stands for sleep disturbances as well as appetite disturbances. Importantly, it's not the poor sleep in terms of not able to sleep or poor appetite in terms of not able to eat, because there are patients who sleep a lot or eat a lot when they're depressed. So it's the disturbances in the form of sleep as well as appetite. The D stands for depressed mood, i.e. you have low mood. CA stands for concentration attention. Remember the case of Mr. Slim we mentioned earlier on? The reason why she left the supermarket without paying for the grocery was because she was not able to concentrate. She forgotten that she was holding some items in her hand. G stands for guilt. Guilt is you start to a lot of self-blame. You start to feel guilty over small minor things. Again, we talked about Mrs. Slim. I did not elaborate further, but she had a maid to help her with her daughter with special needs. So on one occasion, she slapped the maid because she was angry with the maid. And then subsequently, she felt very, very guilty about her action. E stands for energy. The patient complained of poor energy, not able to do anything. And lastly, S stands for suicidal thoughts. So a patient with clinical depression or MDD had to fulfill at least 5 of the symptoms that are illustrated over there, and of which, again, I repeat again, the diminished interest and the depressed mood are the cardinal symptoms. And these symptoms must last for at least 2 weeks, and this symptom must affect or impact the functioning of the individual. Depression and suicide, we do know that 1 out of 7 with current depression commit suicide, and 70% of suicide have a history of depressive illness by looking through the medical records. However, we do know that 70% of persons with attempted suicide or completed suicide see their primary care doctors within 6 weeks of suicide. So it's important for us to understand that when they present to the primary care doctor, a screening instrument to ask them about the mood is very, very important. And women attempt suicide more frequently than men, although men are more likely to die from suicide. We do, when say earlier on, I do say earlier on that the depression is more common in women. Women attempt suicide more frequent, but men successfully committed suicide. Increased risk of suicide are those associated with alcohol, drug abuse, other forms of psychiatric condition like anxiety disorder. Not surprisingly, if there is a significant medical illness or when there's a positive family history of suicide. And if they have poor social support, recent losses or unemployment. Who can diagnose suicide? Definitely the doctors. But who can identify suicide? Any one of you. That's again why I talked about earlier on to increase the mental health literacy. friends, family members, your colleagues, the primary care doctors, counselor, psychologist, and the psychiatrist. Well, how do we identify suicide? Depression, sorry. We take a detailed history. For the psychiatrist, we do a mental state examination by looking at their mood, assess their suicidal intent. You have to do a physical examination. Remember, I mentioned earlier on that a physical illness are more likely to relate to a depressive illness. And we also want to do some form of investigation. A common investigation we do is the thyroid function test, because a person with a thyroid disorder, what we call hypothyroidism, will present with symptoms of lack of energy, tiredness, and some people will think that the person has depression, but in fact it's a thyroid disorder. When to seek help, I always say that a person with depression should seek help when the symptom is distressing or there is a medical complication. For example, we mentioned about the sleep as well as the appetite disorder. So a person refuses to eat will lead to a lot of metabolic disturbances. Or when the person has high suicidal risk or pose a danger to himself or others. For example, Mr. Slim was trying to or attempt or at least have suicidal thoughts to end her life as well as her daughter, because she thought that no one would take care of her daughter with special needs if she passed on. And also a person with poor or no social support. Treatment of depression, as a doctor I mentioned earlier on, you not only prescribe medication, but you just want to emphasize that there are different modes of treatment. Beyond medication, there are the psychological therapy, and there are also other what we call physical therapy like electroconvulsive therapy, the layman called ECT or shock therapy. And there is a new form of treatment called the repetitive transcranial magnetic stimulation, or in short form RTMS. With treatment, 80 to 90% of people with depression eventually respond well and they are able to lead a meaningful life. Just a brief note about antidepressant. All antidepressants are equally effective. They help in 60 to 80% of people who use them as directed. Most people, however, will experience some form of side effects. So when I prescribe a patient with an antidepressant, I will always tell them the benefits, the risks are what we call the side effects, as well as I will tell them that the benefit will take 2 to 4 weeks to appear. That's because of the stabilization of the balance of the neurotransmitter, as I mentioned earlier on. While all antidepressants are equally effective, again, a doctor may prescribe a certain medication for certain symptoms. So if the patient has lack of energy, I will prescribe an antidepressant that is more alerting. Whereas a patient who has problem with sleep, I will give the patient more sedating antidepressant. With that, I need not give a patient an extra sleeping pill, because sleeping pill in the long term may lead to also dependence. 90% or more may eventually respond if a number of different antidepressant or combination of antidepressant is being used. So with the treatment of depression, what are the outcomes? You know, in psychiatrist term, we like to use the word response, remission, recovery, but I think for most people, we probably use the term recovered. But to use the word recovered usually means that the person had no symptoms for at least 6 to 12 months. And if the patient becomes unwell, the next thing we talk about is what we call relapse. And again, I had this problem with advancing the slides. Sorry about that again. Yeah. Okay. So with worsening of symptoms is either a relapse. A relapse occurs when a person has not yet reached a complete remission, but if a person has recovered for many, many years and then start to have depression again, we use the word recurrent. This is not really important for you to know, but it's just to get to know that the reason why we talk about recurrences is because if you have only one episode of depression, the recurrent risk is about less than 50%. But you have two episodes of depression, then the recurrent is at least 50 to 90%. And you have 3 or more episodes of depression, the recurrent risk is almost 90%. So it's important to understand this because it comes along with what we call treatment. If you have first episode treatment, typically, the doctor will prescribe antidepressant for 6 to 9 months. But if you have second episode, i.e. this is your second episode, the doctor will prescribe treatment for at least 1 to 2 years. By the way, this is just a general guide. So it doesn't necessarily mean that by 2 years you must stop the medication. It always depends on, remember what I mentioned earlier on, the perpetuating factors, whether the factors are still ongoing. And if you have third episode, we always encourage the patient to take almost for life. So again, this is a guide. I mentioned earlier on, beyond drugs, what we have also is psychological approaches, and this is what we call psychotherapy, whereby it's in a layman term, is talking therapy. And the most common therapy that we use in depression is what we call cognitive behavior therapy, and this is where I mentioned earlier on by your feelings and your mood and your behavior interplay. There is another form of psychotherapy called psychoanalysis therapy or psychodynamic psychotherapy, whereby we talk about your early days of life, what happened to you, and childhood trauma. And not surprisingly, if there is a problem with individual relationship, we go for what we call interpersonal therapy, or the problem in marriage, we go for marital therapy, or in the family, there is marital therapy or family therapy. So the principle of CBT is essentially, I mentioned earlier on, how the way one thinks determines the way one feels. So the distortion in thinking play a major role in causing and maintaining the distressing feelings. The triad of depression is that the negative view of oneself will lead to the negative view of one's experiences and also the negative view of one's future. A person with depression has this type of thinking, either or none. They tend to think badly about things that happen. They overgeneralize it, or they have a lot of should or ought. I should have done this, I ought to do this. They tend to disregard the positive and tend to jump into conclusion easily. So it's just like the screen that we are in the PowerPoint slide. You tend to maximize your fault and you tend to minimize your strength. So this is where a person with depression, this is their common errors in thinking. We must also emphasize on social support, and since I'm talking on behalf of Kyle this evening, so we need to talk about family support in terms of understanding more about depression. As a family member, you support the patient in seeking treatment and continuing treatment. We also offer to help them in some physical means, for example, by arranging or accompanying them for medical appointment, help them with some physical tasks or everyday tasks. And I think as a parents, as a family members, you also need to be patient with the patient because you do not want to label them as being lazy or being weak, as I mentioned earlier on, and don't tell them that this condition will just disappear by itself. However, I also want to emphasize that family support can come in what we call healthy family support, but it can be also become unhealthy when the parents become overly involved in the treatment. So we start to want to interfere with the treatment of the individual, overly involved. So there is overly involved, overcritical reaction to the family members who suffer from depression. So as a family member, you need to understand that. I just want to end by briefly mention about bipolar disorder, because bipolar disorder, as the term implies, bipolar means there are two poles. So what are the two poles? The two poles are either manic phase or what we call hypomanic or manic phase, whereby the person is very talkative, hyper-religious, increase in activity, they decrease need to sleep. Some patients have grandiose idea, they think they're Superman, they're God, they're special power, they're racing thoughts. And they engage in some activities, for example, they become hypersexual and they will have painful consequences, or when they will start to, for example, invest in some insurance, and buy a car or buy a house without thinking about consequences. So this is just the direct opposite of depression. which I had mentioned earlier on, insect cages. So if a person with depression have an episode of a hypomania or episode of mania, the diagnosis is no longer MDD. The clinical diagnosis will be changed to that of a bipolar disorder. And that also is important because we do not want to give antidepressant just without consideration, because if by giving a person antidepressant, you may end up pushing the mood high and the patient may end up hypomanic or manic episode again. So it's important that a person with bipolar disorder, we need to give them beyond the psychosocial support, maybe the use of mood stabilizer with or without a antidepressant. So it's just to give you some idea about bipolar disorder. So with that, I thank you so much for listening. I think I spent about half an hour. I think we should, for half an hour to 40 minutes. I just want to end briefly by mentioning that this is a session in English. I have discussed with Carl. I do give, so-called write in a local column on depression and other psychiatric condition, in fact, on mental health. And I published a book, and this book is with me over here. If you are interested to get a copy of the e-book, because I think a physical book will be very difficult to deliver to you, that we have about 420 something people attending the talk, but you are interested to get e-book, during the feedback, you can request for one, and I think the organizer will be able to accede to your request. I always send them the e-copy, by the way. So with that, thank you so much.
Thank you so much, Dr. Lee. That was a wonderful and very clear and comprehensive introduction to understanding depression. I would like to now invite our first panelist, actually their father and daughter, but I want to invite Gabriel first, if that's all right. Gabriel, if I could trouble you to please give us a little bit of understanding or background on yourself and what the journey has been like for you from the moment you learned about your daughter's condition and what it was like at the beginning and where you guys are now.
Okay, thanks, Nadia. And thank you, Dr. Lee, for the inspiring sharing, very informative. My name is Gabriel. I'm a retired tech professional and a very proud dad of 4 children. Kristyn is my youngest daughter. She's 20 and she's studying in Monash. Now she'll be introducing herself. Really excited to be part of this program to share our journey with you. I think all of us have been hearing about the grim but real issues of depression. But we are here to share with you that it's treatable and to give you hope. Now, let me share with you, our journey started about 5 years ago. Kristyn is a feisty natural sportswoman. She represented the school in netball, touch rugby. She was even a national rower. And we noticed that when she came back from school one day, she was getting a little more withdrawn. Sometimes she curled up in bed crying, and we were not able to relate to how she was feeling. So that was about 5 years ago. And as any other parent, without knowing what depression is about, I decided that we should quickly seek treatment, which is really the right thing to do, as you heard from Dr. Lee. And we sent her to an art therapist because it was actually recommended by a friend of ours. And then she was diagnosed as having ADHD, and that was something that actually took some concentration away from her. Now, being a very high performer, and she's very self-motivated because she's a sportswoman, is really very difficult for her to really stay focused, in her studies. And I think that was where she started having a little bit of a self-esteem issue. We cycled Kristyn through a series of help, many psychologists, a couple of psychiatrists that were even recommended by the school. It took us a while, and Kristyn is going to go into that to find the right one. And one thing I'd like to share is that building the right rapport with the right psychologist and the right psychiatrist is so important in the recovery journey. I think the other thing, Nadia, that we have also learned in the process in the last few years, what Dr. Lee mentioned is to really have a mindset change within the family. I think depression is not just the individual. It's really the family that has to rally our support around our loved ones. And when I talk about mindset change, it's really in our family, it's really about making sure that, particularly myself, I have to learn to be a lot more patient. I have to learn to say the right things. And at the same time, I have to really give my daughter all the support and unconditional love. And I really do. And the other thing is also to make sure that we are never judgmental. And it's so difficult because when they're going through this difficult journey, they don't choose to behave like that. All right. It's the physio and the psychological makeup of the mind that's causing my daughter to feel that way. And I think so we went through this journey with her, and the more important thing is really the family support. And I'd like to maybe leave the other part of the discussion to Kristyn to share with you a little bit about the recovery journey. So we discovered that she had depression about 5 years ago. We sent her for a series of treatment. And from there, we cycled through to ensure that, she has the right medication. We titrated the medication together with a psychiatrist. And she's in a very good position today. Back to you, Nadia.
Thank you so much, Gabriel. That was great being able to hear from a parent and a caregiver. I would very much like right now to invite Kristyn to share from the perspective of someone who is in recovery. Perhaps, if it's all right for you, Kristyn, can you give us a bit of an overview of what your journey has been like and how much having the support of family members as well as all of the loved ones around you who have been able to help be a rock for you through this journey. Kristyn?
Yeah, so as you guys all know, I was diagnosed with depression 5 to 6 years ago. And I've gone through a lot. I gone through many medications, and I'd just like to tell you guys that the recovery process is just as tiring and challenging as a depressive episode, if not like even more, because it's not linear. There are days where I would feel I took 2 steps back, or I feel that I'm just back to square one or back to zero. And it's just a really bad feeling. But one thing I realized is that there will always be ups and downs, and it's just a blip. The second thing, medication. I've gone through probably 4 types of medication, all different dosages. And sometimes the side effects were more uncomfortable than the depression itself. I was experiencing like nausea, headaches. There were nights where I didn't sleep at all. It was bad, which obviously made me feel worse than I was. And as my dad said, finding the right therapist is so important. I've gone through 6 therapists, and I'm finally with someone who I've been with for the past 2.5, 3 years. And I feel like medication and therapy is so important. And it should be, you need to find someone who works and knows you well. For example, my therapist, I treat her like a best friend. And another thing is that while recovering, I'm not crying, I just have allergies. Another thing is that while recovering, my therapist kept telling me one thing, which is you have to differentiate your depressed voice and your own voice. And I'm really hard on myself. And every time I go through bad thoughts or I spiral down, I need to take a step back. And obviously it's easier said than done, but I take a step back and I ask myself, is this really my depression or is it my actual thoughts? Usually most of the time it's the depressed thoughts. And another thing is that you have to really catch yourself early on. You have to know when you're starting to go through another relapse or something. I actually went through one last month again after a year. It was bad, but I'm surrounded by so many people who love me, and I would say that I know myself a lot more, so I came out a lot stronger. But yeah.
I am so happy to hear that. Thank you so much for being so brave, for sharing your story. There are so many of us in the community who are, in recovery, and I can completely relate to what you said about how we must remember that sometimes is it our depressive voices that has that thought, or is it really our own thought? And so thank you so much for being willing to want to be able to help in this mental health literacy journey. And I just love that we get to hear from you, Kristyn, and of course your wonderful father who is so supportive and having supportive healthcare providers like Dr. Lee as well. So we do have a whole bunch of questions coming in, and they will be for each of our panelists. But the first one that I'm going to start with is Dr. Lee. Dr. Lee, we have a question here from Xin Yu. And the question is actually, can a person get depression over their career, but won't be depressed over relationships? Because we had mentioned earlier that there are some that are triggered by marital issues or work stress. Do you feel that the different factors can have varying responses from the patient?
Okay, I think a very simple answer or very direct answer is that one can be affected by multiple factors. So it can be, and each individual responds very differently. As mentioned earlier on, our psychology makes out our character. So some people may be able to withstand work stress, but at home they have problem with marital issues. And we do know, for example, the last 2.5 years in COVID, there is a lot of reports about spousal violence at home because of the way one manages the stress at home. And there will also be people who are able to manage, for example, at home, no issues because there's a very supportive husband, a supportive wife, or supportive family members. But at workplace, there are a lot of issues related to work stress. They are not able to share with the employers or with the peers. And in fact, I think one of the common questions which I was looking through the question was, so we declare that we have mental health issues, not only specific depression to our employers when we have such a problem. My so-called strict answer is that if you do not declare, you must be well enough to function. Am I right? Because if you are not well enough to function, even if you don't declare, other people will know that you are not doing well. For example, you commit mistake at work, you can't even function, you have poor relationship with others, so you start to become very agitated and become very irritable, you start to shout and scream and throw temper at work. People know that you're not, inverted comma, quote unquote, mentally stable. So it really up to the individual. I always give a choice to my patient. I just want to say that each of us respond differently, and it can be a form of work stress, it can be from marital issues, yeah. And then definitely, if there's a strong family history, then it's more likely to precipitate a depressive disorder. Thank you.
Thank you very much, Dr. Lee. Just another question here that is specific to diagnosis, and I think that it's quite relevant for a lot of us here, especially in Singapore with an aging population. There is a question that I see from Polian. Depression can cause dementia and vice versa. What is your point of view, Dr. Lee? Like, is there the likelihood of someone who has had depression in their life, later in life, will they then be more likely to have dementia? or having dementia is dependent on whether or not there is a history of depression in the family?
Okay. In the first place, maybe I just want to distinguish between dementia and depression. Dementia tend to occur at older age group, as most of us do know that. So usually start at this maybe mid-40s and beyond, unless you have what we call other factors, medical condition that lead to dementia. But otherwise, we're talking about Alzheimer's dementia or what we call multi-infarct dementia, basically due to a minor stroke in the brain. So that is dementia, and it's a progressive disorder. So to distinguish between dementia and depression, a doctor, a psychiatrist, for example, we ask a patient, usually the complaint is that a patient with dementia, especially in the early stage of dementia, they do know that the memory is getting poorer and poorer. So what they do, they tend to try to their best to answer. So you ask you what you take this morning, you try to answer. Even you think that vaguely you can't remember, you try to answer. Maybe I ate roti prata this morning. Okay, it might be wrong, but you try to answer. Well, a person with depression, then essentially their mood is very low. They have no urge or no interest or no energy. So they tend to answer what? I don't know. So I don't know answer is the typically answer from a person with depression, whereas a person who had dementia, especially in the early phase of dementia, they tend to answer, try the best to answer, but it may be wrong. And they may end up what we call confabulate, which means they try to give a wrong answer, a false answer to a question. Then the relationship between dementia and depression is like what we said earlier on. Any psychiatric condition have what we call comorbidity. So dementia, depression can also have anxiety symptoms. So a person with dementia, for example, once you start to know that your memory is getting poorer and poorer, you start to get worried. Am I right? When you get worried, you may have depression, especially with prolonged worry. But in the beginning phase, we tend to answer what we call adjustment, because you are adjusting to a new diagnosis or adapting to a new diagnosis, just like a person with cancer. But a person with cancer can also have depression because you can't believe that at this young age, for example, I had depression, I had a cancer. So you have what we call secondary depression. So a person with dementia can have secondary depression, but it can also concurrently happening together. I hope I answered the question concise and for most to understand. So it doesn't mean that you had dementia, you cannot have depression, or neither to say that you had depression, you cannot have dementia. Yeah.
Thank you very much, Dr. Lee. That was very comprehensive. My next question is actually for Gabriel. Gabriel, as you know, our community here is a community of caregivers. And even for myself, I have a sister who grew up with mental illness, and I watched my parents struggle with trying to navigate caring for our loved one. What has the journey been like for you, and perhaps your wife as well, and in your family, and trying to navigate the stigma and also the fears, trying to address the fears of your loved one? I remember you and I did a video together in 2020 where we essentially talked about what it was like for caregivers and trying to take care of and protect our loved ones, but also at the same time wanting to be able to do justice in terms of advocating for them and helping the wider public understand what it means to have a mental illness. Can you tell us a little bit of what that experience was like for you?
I think, Nadia, the entire experience, even now, is very humbling. Me and my wife, by the way, I don't really like to be called the primary caregiver because it's really the family effort. In fact, I think kudos really goes to my wife because she is there for Kristyn all the time, especially whenever she has dips. Being a guy, I've just decided to take a back seat in terms of my career. That was about 2 years ago. And to connect with my daughter, because I found it so hard, to really connect with her before, right? So what my family did was we cut up our roles in addition to the mindset change, to be more understanding, to be more patient, and to be more loving. When I talk about cutting up our roles, let me cite some examples. I'm a doer, and we have to realize our strength. So basically, I drive Kristyn around, drove her to school, I follow her to Melbourne, and I kind of do things with her. And sometimes, you know, when she has dips, I get her a flower or two, you know, just to cheer her up. For my wife, she is a rock, you know, she's always sitting there with Kristyn, even when she refuses to talk, and she gives her space. And that's important, you know, because Kristyn realizes that we are there for her. When it comes to the brothers and sisters, she kind of identified two siblings, the younger brother and also the older sister, as her go-to person. Even though my eldest daughter works in the US, I know they WhatsApp a lot. They've been sharing a lot, and she feels safe, you know, to communicate with her. And for my eldest son, Mitchell, you know, she basically goes for a walk with him, bakes with him, and basically do stuff with him. So I think it is not about just me. It is really about the entire family and her friends. And she's got a bunch of good friends, you know, that really support her in this whole process. Now, with regards to advocacy, I'm thankful that Kristyn is so supportive of this, especially after the episode. She was willing to step forward, you know, to talk, and in today's session as well. We strongly believe it is important for everyone to know that, like what Dr. Lee said, it is treatable and there is hope. It doesn't matter whether it's 6 months or 6 years. This disease is just like any other diseases. It can be treated. Nadia.
Thank you so much, Gabriel. I am genuinely happy for Kristyn that she has such a wonderful support system around her. And also, I want to thank you, Gabriel, as a parent. I'm trying not to get emotional because obviously this hits home. Yes, there is a follow-up question that I have for you, Gabriel. I mentioned earlier, you know, how as caregivers, we tend to feel very protective for our loved ones. And part of that journey is also having to address or grapple with a lot of the ignorance or stigma or misinformation or people who don't quite understand what it means living with a mental illness. Can you share with us, and I'm sure there are a lot of people in our community tonight listening today to our fireside chat, where a lot of them feel very pained, where they're on the one hand trying to care for their loved one, but also at the same time, they receive a lot of negativity from the people around them who are supposed to be their friends or family. And what was it like for you, Gabriel, as a caregiver, as a parent, trying to get through that?
Yeah, I think the first thing for us is that this is not like a flu, you know, that you can just go to a GP and get a dosage of antibiotics and be well in a week's time. We need to be informed. And I think that our government is trying their best. I know that MOH has set up a task force to come up with an overarching program for the entire nation to make sure that, you know, from the ground up, everybody understand what mental illness is about and to dispel this myth. The thing is that for myself, you know, I sign up for C2C just to understand what are the causes, how do we address and engage. Through this 9-week course, I've gained a lot, but it doesn't mean that, you know, I understand how to deal with it because it's difficult and I do not know what goes inside Kristyn's mind. Now, the thing is, with that, you know, I'm better equipped. And I think even for my family, you know, they feel that, you know, they understand what this is. And we continue to come together, you know, to support the cause. And the main thing here is we really want to make sure that people knows that this is something that is treatable, and as long as they go for the treatment early and with the right psychiatrist and psychologist.
Thank you so much, Gabriel. Thank you so much to you. Thank you so much to your family. I hope that people walk away from tonight understanding that it is possible to be able to care for your loved one as a united front. And I hope that more caregivers out there have been inspired by your story as well as your family. If I could just bring Kristyn into the fray now. Kristyn, are you okay?
Yeah, I am.
No, I don't know if it's your allergies, but I know for me it definitely hit a chord because I go through this with my own family. But let's try to lighten the mood a little bit and talk about some of the more heartwarming, positive effects of what you've been able to see with the people around you and how their support has helped you in your journey.
So as my dad has said earlier, whenever I'm down since high school, if he notices I'm down, he would always buy me a bunch of roses, always red roses. And it makes me feel really happy and loved because it just shows that he himself knows that whatever he says won't make me feel better. But he goes out of his way to find alternatives in order to brighten my day. And yeah, it's just really heartwarming. The second thing is, I think, words of affirmation and encouragement, because when I'm down or I'm going through a tough time, again, I'm not crying, it can be hard to recognize and acknowledge your own achievements or who you are as a person or how good you are. So, and it's also hard to see how far you've come or your own progress. So that's when I have my friends and family come in and tell me and remind me actually how far I've come or who I am as a person. And as my dad said, spending time, because when I'm down, I do not leave the house, but that's something that you shouldn't do, because you will spiral even more. So that's when my brothers try to get me out of the house, try to do things. But saying that, my family do still give me space, which I really, really appreciate. They are not always on my back. They're not trying to shower me with love. They allow me to have the space that I need. Yeah. And saying all this, everyone's different. What works for me doesn't mean it'll work for whoever your loved one is. And the saying goes, to each their own. Everyone has their own preferences. So don't feel worthless, or don't give up, because whatever you're doing, maybe continue doing it, or maybe try to change up what you're doing or understand the person even better. And yeah, I really think it's important to see, to never tell them what to do. That is so important. Never ever tell them what to do or what they should do, because you never fully comprehend what they're going through, or you never know like how they feel. So I feel like it's your compassion which actually validates how they feel and their experiences. So yeah, and when people actually validate that it's okay to feel how I am, I just feel a bit better. It sounds weird, but I really do. But yeah.
Thank you so much, Kristyn. And you're absolutely right. For different people, it's different things, right? Whatever works better for you and whatever helps you feel better in that moment. Now, before I move on to my next question, which I actually do want to address to Dr. Lee, because I want to bring it back to a little bit more of the medical side, technical terms, I want to ask our all of you out there, if you could kindly type in our group chat, what makes you feel better when you're having a bad day, when you're down? Is it take a walk? Is it make yourself a cup of tea? Because anybody who's listening, who's watching right now, will probably want to look in the chat, and they're all and we want to be able to hear from each other, to learn from each other, because that's the point of having a community. Tell us, share with us, what do you do to help you put yourself into a slightly better mood when you are going through a rough day? Now, while all of you are doing that and typing into the chat for us, I would like to ask Dr. Lee a question. We do have some caregivers in our community, or it isn't always a case where our loved one has actually gone through the process of getting diagnosed. The reality is a lot of us are here because we're trying to learn, because we've observed or we are concerned with certain signs that we see in our loved ones. What advice do you have for us when we are worried about someone who is showing significant signs but are not yet at that point where they believe that they need to get mental health help?
Thank you, thank you. I think I earlier on emphasized the importance of early treatment, and also I mentioned earlier on also about the reduction in treatment delay and how it came about. Essentially, I believe importantly is to increase the mental health literacy. You do not know that you're suffering from something, you will never seek help. Am I right? I think that's very common. If there's a lump in your body, you think that it's benign, you think that it will grow. I mean, that growth will disappear by itself, you will never see a doctor. So I think it's importantly we need to increase the mental health literacy of the whole population. Like what Gabriel mentioned, I see it also in the as a president of Singapore Association Mental Health. I see in the task force that he mentioned earlier on, the interagency task force, that's chaired by our SMS, Dr. Janil Buttigieg. So these are the areas of mental wellness that we need to talk about. So I always in my department, Office of Population Health, I emphasize a couple of things. First, what are the factors to be mentally healthy, or we call positive mental health or mental wellness? Two, what are the common psychiatric conditions one need to understand, not to have a degree or a diploma, but at least have some understanding so you know when to seek help. But again, this was emphasized earlier on, the destigmatization effort. Because you do not destigmatize it, you do have the symptom, you may not seek help because people think that going to see a psychiatrist must be a danger, or you are potentially going to be violent or commit crimes. Fourth, and again, this was emphasized many times by Kristyn and also the father, Gabriel, is how to communicate to one who have some psychiatric disturbances or a mental health distress. It may not be necessarily a mental health disorder. And lastly, where are the resources? So the mental health literacy in terms of what are how to maintain mental healthy, what are the common psychiatric disorder, the destigmatization effort, and earlier on the resources and how to communicate with one with mental health issues. But I also want to address this issue about where to seek help. I think I saw that question be reflected a few times. I think if you have mild to moderate symptoms, you probably can see, and I mentioned just now, anyone can notice you having a psychiatric disturbances or mental health distress. You can see a counselor in the community. You can see your school counselor. You can see, or you can even approach a spiritual healer, because some of us may not talk to a professional in terms of a doctor. So we may get support on the spirituality. I think that's very important, spiritual support. Okay. And also want to emphasize that not every patient requires treatment as in terms of medication. We talk about medication, but usually medication is for what we call moderately severe. For the mild to moderate, it needs the support from the family members, the support from the society, and the support on oneself. I think the self-awareness, the self-care. There is also a question, I just thought I would answer a few questions at the same time. There's also a question about, for example, ECT. You say, why is it continue on? Can we go proceed with ECT without the person consent? I just want to give this a simple diagram of a triangle. And the triangle, on the tip of the triangle, is always the patient. Always the patient comes first. As long as the patient has the insight into the illness, the understanding, the patient always comes first. The other corner of the triangle is the caregiver, like what Gabriel mentioned, may not be what we call primary caregiver, but the parents, the family members. And the third corner is the therapist, be it the doctors or the psychologists, the counselor. So we work hand in hand together. But this triangle lies in the circle. The circle is the society, the community. So the community needs to be inclusive. The employer we mentioned earlier on, the workers and whatnot, the peers need to be inclusive to support the individual and also support the treatment. Otherwise, the treatment will be deemed to be so-called bad work. If you, for example, talk about ECT, it's still a scientific proven form of treatment. And so I think this is very important. And there's a lot of also question about how people suicidal thoughts or suicidal ideation. I just want to also address the question, because suicide may not necessarily be a person who are depressed sorry. It may be an impulsive act. A person may do it in an impulsive manner. As I mentioned just now, 70% of post-mortem, we do a medical records, they have some symptom of depression. So I think it's important to recognize that suicide may be a symptom of depression, but it can also be a impulsive act. So we do not want to label everyone who do a self-harm to be having a depression, because we also do not want to over-medicalize a patient or over-diagnose a patient and start to treat them with medicine unnecessarily. So we want to weigh the balance about the what we call the view from the patient, the view from caregivers, as well also from the doctors and the clinicians, and that's very important. And the last question I thought I want to address is also mentioned by both Gabriel and Kristyn, is seeing different doctors and in the end find the right doctors. I always say that the right doctor is the doctor that you can build, or the right clinician, be it the therapist, is one you have a rapport with. It may not be very, very senior doctor or a very, very go to see a doctor who's very so-called a lot of qualifications. The one that you can build rapport with, the one who can share with you, at the same time you can share with him or her. I think that's very important. Ideally, offer a listening ear, because I always say that you keep talking, what you are doing is why am I talking? And you keep talking non-stop, why am I keep talking? So most important, offer a listening ear before you give judgment and before you give advice. Thank you.
Thank you so much for that comprehensive response, Professor Lee, because I too was trying to run through our chat, trying to capture the key questions. There is one question, Dr. Lee, if I may ask. We remember that Kristyn mentioned, even in her own experience, her journey has been it's non-linear. Some of us can have episodes at different points in our life, and especially people in the community who, like myself, who are in recovery, we talk about the recovery journey. And then there are some of us who say that I live with depression. This is a question that Shanna May wrote in our chat. Is a question that she has. So from your point of view, Dr. Lee, what do you see is the definition of recovery? Do we actually get to there are cases that come to a point where they no longer need medication and they no longer consider themselves suffering from depression, and in your opinion, are there those who really do live with it and they just learn to live with it?
Okay, I think that's a very, very important question, and also a very fundamental question about mental wellness. I just want to emphasize that you and me, we may not have a psychiatric diagnosis, but we may have distress in our life and they are not functioning well. We start to become argumentative, irritable. We do not fulfill the criteria of 2 weeks or the symptoms of insect cages. But we are not having a good mental health because we are a lot of stresses. Similarly, a person who has been diagnosed with a mental health condition, be it depression, schizophrenia, or bipolar, or whatever diagnosis, but if the person know that what are the triggering factors, able to manage the stresses, have a good social support, and is need to comply with the treatment, the person with a mental health disorder also could have a good mental health. So a good mental health doesn't necessarily mean that you have no mental disorder. A person without a mental disorder may have poor mental health if you do not cope with your life stresses. So what I'm trying to tell you is that a person in recovery, that again is highlighted many times about hope, can still function very well, despite the fact that the person is on treatment long term. I have patients who have seen me for many, many years since the day I graduated until now, for the last 20 over years as a psychiatrist, but they are doing very well. But patients who may not be seeing a doctor but doing very unwell, as in they have multiple readmission because of taking medication or poor social support or not able to cope with the stresses. So I think we need to delink mental health and mental disorder. So with that, I hope I addressed the question about recovery.
Thank you very much, Dr. Lee. You did, and I appreciate that, and I'm sure people in our community appreciate that too. I think more than anything, and I'm sure Kristyn will agree with me on this comment, is that most importantly, be kind to yourself. This journey is difficult for everyone, from from the perspective of patient, but also from the perspective of our caregivers, the loved ones that surround us, and trying to be there for us and support us. So, in just to bring this session to a wind down, I would like to invite Gabriel, if I may, to give what advice you may have for other caregivers out there, or maybe more specifically for other parents out there who are caring for their children who are trying to navigate this journey. What would your advice be?
My advice is to seek treatment early. Do not live in denial. I think many of our parents out there are living in denial and hoping they will step out of it, and this is not going to happen. The second thing is we have to rally our family together to support them, to love them. Fundamentally, the common denominator is without the family support, most of them will have a longer time to recover. The third thing is to continue to stay positive. We have to be very positive because this is something that's treatable, as evident in Kristyn. She's in a very good space right now, and talk through it. I encourage all of you to talk through it because we want all of them to be inclusive in our society, and they are as capable as any one of us. So we want to make sure that they're included in our society today. Nadia.
Thank you very much, Gabriel. Those are very powerful words, and I do hope that everybody takes that to heart. I want to ask Kristyn, if I may, to kind of give your advice or some parting words to anyone out there who either knows somebody who is in the process of recovery, or somebody who happens to be listening in tonight because they themselves know that they are trying to get their life back on track. What would your advice or parting words be for people in recovery, Kristyn?
My two main points. The first one, as I said earlier, to each their own. Everyone is different. Everyone has their own preferences. It might work for some people and it might not work for others. But you have to take the time to get to know your loved one. And the second thing is, don't feel hopeless or worthless, and don't give up, because I promise you, coming from me, the past 5 years, everything I've gone through, I promise you, really small things make a difference. And I still remember everything that my friends and family do, especially my dad, till this very day. So continue supporting your loved ones and being there for them, as I said earlier, but still give them the space that they need, because they don't want to feel that you're always on their back. Yeah.
Thank you, Kristyn. I look forward to continuing to being able to stay in touch with you in future, as well as Gabriel. And I really appreciate, on behalf of the community, thank you all so much for your advocacy and wanting to help raise awareness. Before I let all of you go, I would like Dr. Lee, do you have any parting words before we wrap up for the evening?
I just want to echo what Gabriel and Kristyn has just mentioned. I think it's important for us to have a so-called support of family members, but I also want to emphasize importantly on self-care. I think as a caregiver, sometimes there will be a lot of distress taking care of someone with a mental condition, mental health disorder, or a neurological disorder or developmental disorder. So do take care of yourself as a caregiver. I think that's important because they are also, we do know that caregivers are more prone to also mental health distress. So as a caregiver, I wish you all, because on behalf of Cal, I hope that you all understand not only the condition that your loved one is suffering from, but importantly, do take care of yourself. Just like when on the plane, always when there's turbulence, the stewardess will say, please take care of yourself first before you take care of the person beside you. With that, thank you so much.
Thank you all so much. Thank you, Dr. Lee. Thank you, Gabriel. And special thanks to Kristyn for being with us this evening. I thank all of you for taking the time to be present with us tonight, for attending our fireside chat. I ask you to all please, take the time to send us your feedback. We will be sharing a survey at the end of this. Again, tonight's session is recorded, so you will be able to watch it at a later date. Which you will receive via email. And of course, if there is anyone out there who has any additional questions that we weren't able to get to today, please do feel free to get in touch with us, send us an email. And we will also be sending you the link for you to be able to read Dr. Lee's ebook. In the meantime, please don't forget to follow us on our socials, Caregivers Alliance. We are on Facebook, we are on Twitter, we are on Instagram, and we are on LinkedIn. Are we on TikTok as well? Yes, we are on TikTok as well. Thank you all so much. Have a wonderful evening. Please stay safe, and we can't wait to see you again at our next fireside chat. Good night.